everybody, it is Miss Rachel here with iCode Academy. Today is going to be my very first video in a series for evaluation and management coding, and we're going to start with breaking down the history. So let's get started. So the history. This is going to be the very first of three key components that is necessary for your E&M or evaluation and management coding, as well as the documentation. This is really going to be a narrative element that provides the background for the encounter. So in other words, why is the patient being seen? Another way to look at this is the subjective portion of the encounter, and it's going to be the patient's interpretation of why they're there. Why are they being seen, as well as elements for the encounter that is from their point of view. So let's break it down. For the documentation, as well as the elements required to support the evaluation and management coding within the history, we're going to need a chief complaint, as well as the HPI or the history of present illness, the ROS or the review of systems, and lastly, our past family, social, and medical history. So let's talk about that chief complaint. A chief complaint is going to be required for each and every E&M or evaluation and management visit. And this is going to be that somatic complaint from the perspective of the patient. So a lot of times this is, I have a headache, I've got chest pain, or even a statement from the staff is acceptable, such as a registered nurse or a medical assistant. And they might say or reflect in the documentation, the patient's coming in for an ER follow-up, or they're here for their annual or physical exam. So let's talk about that HPI. HPI, again, is going to be the history of the present illness, which is really going to describe the clinical problem. For each E&M counter, some level of HPI is required, but the extent of what is required is going to really depend on the medical necessity, which is up to the provider who's seeing the patient to determine that medical necessity. So your role as a coder is to read the documentation appropriately and reflect or level out all of those elements, but not to determine to what extent it is necessary for the provider to complete and document the HPI. So let's look at the 8 HPI elements that you can find within the documentation. The first one is going to be the location. Next, we have quality, severity, duration and timing, as well as the context, modifying factors, and lastly, our associated signs and symptoms. So let's look at each one of those individually and describe what they are and some examples that we might see. So I want you to take a look at the screen that I have up here for you guys. Please keep in mind that these are just examples. This is not an all-exclusive list. This is just common elements that you might see within the documentation. So first and foremost is location. This is usually very common to see within the documentation. So the patient's coming in and they might state that they've got a pain in their left knee or some kind of lesion or cyst that's occurring above their right eye. So location is going to be that physical location on the patient's body where their signs and symptoms are occurring, or that chief complaint. Next one we've got is severity. It's very typical for providers when you come in to the doctors to say, on a scale of 1 to 10, how would you rate your pain today? So when we see this documentation within the note, we can go ahead and give credit for the severity element. Providers can also document this stating that the pain is mild, moderate, or severe, as well as the symptoms. It doesn't always necessarily have to be a pain factor. Let's use a common symptom of diarrhea, for example. The provider could say that it's a mild form of diarrhea or a severe form of the condition. The next one is going to be duration. This is going to be based on a specific amount of time. So for example, that patient that had chest pain, maybe the chest pain started 3 days ago, or there may be a discharge from a recent biopsy, and following that biopsy, that's going to be the duration of that new symptom. Modifying factors is the next one. This is going to be what steps has the patient taken or not taken to alleviate the chief complaint or the problem. So maybe the patient has been trying ice, physical therapy, Tylenol, or even documentation stating that the patient hasn't tried any of these. That is still going to be a reflective element that we can go ahead and take as a modifying factor for the HPI. All right, let's look at the next one, number 5, quality. This is going to be descriptive terms. So when we're talking about the pain is sharp, it is a throbbing sensation. All these descriptive terms are going to be a quality HPI element that we can go ahead and take to support the history. Next one is going to be timing. Timing in the documentation may state that something is worse in the morning, improves in the evening, usually occurs after the patient is lying down or sitting up. It kind of explains when this is happening without it being specifically a time duration element. Because if it is a time frame, 3 days, 5 days, this has been happening for 6 months, we're going to use that as duration in comparison to timing. The two of those sometimes can be a little bit confusing for coders. So when I'm working with duration and timing, I always like to think timing is going to be when this is occurring. Duration is how long has this been occurring. So those are the questions that you want to ask yourself to properly give the provider credit for the correct HPI element. The next one's going to be context. Context is not something that you typically see in the documentation for chronic symptoms or illnesses, more in regards to injuries. So the context is going to say what happened or what was the patient doing when this occurred. So let's go back to that left knee pain. The patient has pain in their left knee and the provider says, well, what triggered this? What happened? And the patient says, oh, well, I fell off of a ladder or I slipped in my driveway. That's going to be the context of the chief complaint. But if the patient's a diabetic, for example, the provider is not going to say, well, what happened for you to be a diabetic? How did this occur? What happened for this condition to manifest and form? The patient's not going to have an appropriate context for that specific chief complaint or that reason for the visit. So just keep that in mind. And lastly is associated signs and symptoms. The associated signs and symptoms is additional signs and symptoms that is above and beyond the chief complaint. So with that left knee pain, the patient could say, I've got this left knee pain, which is going to be their chief complaint as well as a location. But then the patient could also say, it's radiating and it's really going down into my ankle. So that ankle pain is going to be an additional sign or symptom. Another element that we could have there is maybe additional swelling or there's some numbness or tingling going on in some of the extremities. So this is where we could take additional concerns above and beyond that initial complaint and associate it as a sign and a symptom of that chief complaint. One tip I want to give you guys is let's make sure we're not double dipping or double counting these elements when we work on our review of systems. And I'll get to that in the next couple slides here. All right, so let's talk about the levels of the HPI. For the HPI, there are going to be 2 levels. A brief HPI requires 1 to 3 elements. So for example, if we have that location, severity, and duration, we've got our 3. It's going to be a brief HPI. If we have more than 4, this puts us in an extended range. So if we've got location, timing, severity, and associated signs and symptoms, now we're at 4. So we want to make sure we appropriately level that out to an extended HPI. The only kind of little trick here or thing you want to keep in mind is if you are using the 1997 Evaluation and Management Guidelines, it does allow for you to have the status of 3 chronic problems to qualify for an extended HPI. And you can see that in the screenshot that I've included for you of the leveling tool down below. So again, if we're using 1997 Evaluation and Management Guidelines, you can use the 4 HPI elements or the status of 3 chronic problems. So what would the status of 3 chronic problems look like? Let's go back to that diabetic patient. Say you're coming in for a follow-up. You've got diabetes, which is a chronic problem, hypertension, and you're also following up on your asthma. So right there, addressing those 3 problems and having some HPI elements on those 3 chronic problems is going to qualify the provider and support an extended level of HPI for coding purposes. We'll look at that a little bit more here, especially in the next video when we talk about breaking down exams. So let's take a look at one of these together. First line here, we can see that it says CC, patient complains of red eye. So CC again it's going to be our chief complaint. So we have a patient complaining of a red eye. This began 2 days ago, which is going to be our duration element. That 2 days ago is duration. The complaint is limited to the right eye, so we can go ahead and take that limited to the right eye as our location. It's worse in the morning, which is going to be a timing factor. And the lids are stuck shut with discharge. So that discharge is going to be an additional sign and symptom above and beyond the redness of the eye. So right there, you can see that we do have a total of 4 HPI elements when we count them out. All right, let's look at another one here together. Let's go back to that patient with the chest pain. Patient complains of chest pain, which began 3 hours ago. Pain has been on and off since that time, with each episode lasting 2 to 3 minutes. The pain is described as crushing, and at times is rated as an 8 on a scale out of 1 to 10. The pain occurs with minimal exertion and is associated with nausea and shortness of breath. The pain was relieved with a sublingual nitro in the ambulance. All right, so let's pick this note apart and find our HPI elements. We always want to make sure that we have a chief complaint, which we do. Here we can see it's chest pain. All right, so let's start with that HPI. First thing I want to point out to you guys is the documentation that says chest. What are we going to take that for? When they say that the complaint is in the chest region. Think about that. Next, we have our 3 hours ago. So chest we're going to take as location. 3 hours ago is going to be our duration element. Next one here, we can see that the pain has been going on for 2 to 3 minutes, which we can take as a timing element. How long has it been going on? Pain is described as crushing. So remember when I talked to you guys about descriptive terms? Descriptive terms are going to be our quality element. Then we can see that at times they rate it at an 8 on a pain scale of 1 to 10. So this is going to be the severity. How severe is the pain for the patient? The pain occurs when minimal exertion. So when the pain occurs, that explains to us the context. What is happening? We also can see that the patient is experiencing nausea and shortness of breath in addition to the chest pain. So right there, we're going to take that as an associated signs and symptom. And lastly, we have a modifying factor where the provider indicates that the pain was relieved with a sublingual NTG, or that is a nitro. So let's add all these up, and we can see we have a total of 8 elements. Anything more than 4 is going to be that extended HPI. All right, awesome job. Let's do another one. Oh, just that one. Sorry, I got ahead of myself. Let's talk about the review of systems. This is going to be the next section within the history. So again, remember we had our chief complaint, then we followed up with the HPI. Now we're moving on to the review of systems. Review of systems is going to be an inventory of specific body systems or areas by the provider. This is designed to bring out additional clinical symptoms which may not be relevant with the initial chief complaint. The thing to make sure that we are properly attributing these to are questions that are asked by the provider. So this is the provider saying, do you have headaches? Are you experiencing any fatigue or weight loss? These are specific questions that the provider is going to ask based on the medical necessity of the chief complaint and the patient's ongoing history. Review of systems guidelines are going to apply equally to 1995 and 1997 evaluation and management. And again, I just want to reiterate that the extent of the review of systems that is documented, that medical necessity piece is up to the provider and based on their judgment. So your role as a coder is really just to make sure that you are locating them and you are leveling them and counting them up correctly. So let's take a look at those. Here we can see we have constitutional, eyes, ears, nose, mouth, and throat is going to be one system altogether. Cardiovascular and respiratory, GI or gastrointestinal, GU or genitourinary. We have musculoskeletal as well as the integumentary system, which is the skin and or our breasts. Neurological, psych, endo. We also have hemo and our lymphatic system. And last we have the allergies and our immune system. So when we're talking about the levels for review a system, we have a total of 4 here. Again, keep in mind with our HPI, we only had 2. So now we're moving up when we have a total of 4 various levels. What we're going to do just with our HPI is add up the systems that were reviewed, and those are going to correlate to very specific levels for the review of systems. Here you can see a brief HPI is no review of systems. So you can have a evaluation and management encounter with no review of systems reflected. If there is 1 review of systems completed, that is considered an extended review of systems. Detailed is going to be 2 to 9 systems, and comprehensive or complete requires more than 10 systems. Here I want you to take a look at the examples. Again, not an all-exclusive list, just a couple examples for each system that I've commonly run across in my experience. So here we can see for the skin or integumentary system, provider might document or ask the patient about rashes, itching, maybe any changes in their hair or their nails. Head could be maybe head injury, any headaches going on. And the headaches can also go along with neurological. You'll see that towards the bottom of the list here. Reviewing the systems as far as eyes is concerned might be double vision, any changes, seeing flashing lights, as well as when did they have their last eye exam. ENT is going to be any changes in our hearing, nosebleeds, any frequent colds. Let's move on to going down the list a little bit further, talk about cardiac, as well as respiratory. Respiratory is going to be, any shortness of breath, any cough. Are you coughing up phlegm or any type of a wheezing? Cardiac or cardiovascular. Does the patient have any blue fingers or blue toes? Is there any rheumatic disease, any swelling or edema, when we go back to our medical terminology, in their hands or their feet? GI or our gastrointestinal, is there any problems swallowing, any heartburn, vomiting, diarrhea, change in your bowel habits? And moving down to the very bottom of our list here, I just want to quickly touch on psychiatric or psychology. Here we can see any documentation of the provider asking about anxiety, depression, any issues with your memory, any problems sleeping, any changes in your mood or overall effect. So that's just a few of the examples that we might see for our review of systems documentation. So let's talk about the documentation guidelines. When we're documenting, or when the provider is documenting, and we are counting up the elements as far as review with systems, it is recommended that the providers document all positive and pertinent negatives responses when they are asking these questions with the patient. Again, the extent of what review with systems elements are necessary is 100% up to the provider. So let's say that the patient comes in and their chief complaint is, I have a cold and I've had this sore throat. The patient doesn't have any chronic conditions. They're young, they're healthy. It would be considered normal or acceptable for a provider to do a review of systems, maybe about fever, any problems going with your eyes, ear, nose, throat, as well as respiratory. It would be unusual for a provider to ask maybe about neurological issues or maybe skin issues if the patient just is coming in with a cold and sore throat. But again, that extent of review of systems is up to them. So let's take a look at some of the documentation as far as the review of systems statements are concerned that is considered acceptable. Here we can see that the providers typically document ROS, or review of systems, negative for fever, changes in vision, discharge, and or difficulty breathing. Positive for pressure and sinuses, as well as difficulty swallowing. So here we would go ahead and pick out our review of systems elements. So we have fever, that's going to be a constitutional element. We have eyes for changes in vision. We also have respiratory for the difficulty breathing. We can take ENT for the sinus pressure, as well as the difficulty swallowing. So when we add those all up, we can see that we fall within that 2 to 9 range, and this would be an extended review of systems. The statement that you see here at the bottom is one of many statements that would be considered acceptable for providers to be given credit for a complete or comprehensive review of systems. So here you can see the provider documents all other systems were reviewed and are negative. So that is the provider saying, I reviewed all of their systems, everything else is negative besides what I documented in my note. It's not necessary for the provider to list out like all 10 or 11 systems that they reviewed and put negative, negative, positive. That's not necessary, and it's not required. So they are allowed to document 1 or 2 of them that may have pertinent positives or negatives, and use this kind of a canned statement that is acceptable for them to get credit for a complete review of systems. So as coders, let's make sure that we are counting those elements out correctly and giving them credit for the elements that are reflected. All right, last element or section of the history. Let's talk about our past family, medical, and social history. Our past medical history is just that. Past illnesses, maybe procedures or surgeries that we've had done. Some other elements that maybe don't seem as intuitive are documentations of our current or past medications, our allergies, any dietary status, as well as our immunization records or immunization status. Are they up to date on their immunizations? Have they had a flu shot this year or not? That's all going to be acceptable documentation to support our past medical history. Next one is going to be our family history. This could include status of living or deceased family members, any hereditary conditions, or conditions that are specifically related to the chief complaint. And lastly is social history. The social history is really going to depend on the age of the patient. This may include marital status, employment, any drug or alcohol use, sexual history, the level of the education, as well as living arrangements. So let's play a little game here. I have up on the screen here for you guys a few elements I want you to take a look at. So here we can see in the upper left-hand corner, we have some construction workers. Right below that, we have a diploma. Moving a little bit over towards the right, looks like we have a patient who is not a smoker. Next to it, we have a worn out and fatigued heart. All the way over to the right-hand side, you can see a procedure taking place. Moving down to the bottom of the screen, we can then see that we maybe have a loved one that has passed away or a family member. And right back over to the left, we can see that we have some conditions or maybe illnesses that are running within our family. So let's put these in the appropriate category as far as our past family, medical, and social histories. Here we can see that our social history is going to be that employment, education, as well as our status for smoking or drug use, as well as alcohol use. Next, we have our medical history. So if we have congestive heart failure or we've had prior surgeries, this is all going to be a part of our medical history. And if the provider is documenting that we have a loved one or a family member who has passed away, as well as any chronic conditions that run within our family, this is all going to be our family history elements. All right. So for the levels of the past family, social, and medical history, just like review with systems, we have a total of 4 various levels. The brief is going to be no elements. So no documentation or indication that the medical, family, or social history was reviewed would be considered a brief level as far as the histories are concerned. An extended problem focused, same thing. It's going to be no elements. So you might be asking yourself, well, what's the difference? How do I know if I say this is a brief level as far as the histories are concerned or extended? Because they both don't need any review. Let's talk about that when we put this all together in just a second, but I want you to keep that in mind. Next, we have detailed. So this is going to be one area for an established patient. So either the past, family, or medical history. Or for a new patient or an initial consult, it could be 1 or 2. And comprehensive. This is going to be 2 or 3 areas for an established patient and at least or all 3 areas for a brand new patient. So you do need to determine here if the patient is established to the provider as well as the practice or if they are considered a new patient. We'll talk about that a little bit more in our next video when we break down the exam. But as a reminder, a new patient is a patient who has not been seen in the last 3 years. An established patient is a patient who has been seen by that provider in the last 3 years. All right, now it's time for us to put this all together. Here's an overview. I want you to take a screenshot, take a really good look at this. I'm going to kind of hang out here for a minute of the 4 levels of history, and then it breaks them down on by HPI, review of systems, and our past histories. So here you can see an overall problem-focused history requires a brief HPI, no review of systems, and no past family or social or medical history. The next level is an expanded problem-focused history. Here again, we need a brief HPI, but we do need at least 1 review of systems. And then again, no past family, social, or medical history is necessary. Our third level when it comes to our history is going to be the detailed level. Here we need an extended HPI, 2 to 9 review of systems, and 1 past family, social, or medical history. And the last and final level when we're tooling out or leveling our history is going to be comprehensive. This needs a extended HPI, at least 10 or more review of systems, so that's that complete review of systems, as well as all 3 are past family, social, and medical history. All right, so let's take a look here. This is going to be a daily care note, which is our inpatient every day, they're checking in on you documentation. We can see that we have a chief complaint, and then the history is very minimal. We have 1 sentence. The patient's left flank pain was resolved. All right, let's pick it apart. We have left flank pain. That is going to give us our location when we talk about our HPI. Moving on and using the entire section of our leveling tool to find out our overall history. Again, we have location, which is going to be our brief HPI. We didn't have any review of systems. We didn't have any documentation as far as our past family, social, or medical history. So overall, this is going to give us a problem-focused history level. Just that one line, very simple. That's all you need. Let's look at the second example I got here for you guys. This is going to be an office visit, so a clinical encounter, and it looks like the patient's established. Chief complaint says the patient's coming in for a follow-up of their allergies. Interval history, patient's nasal congestion has significantly improved with steroid nasal spray and is now described as mild in severity. Review of systems is negative for cough, hoarseness, or shortness of breath. So let's start picking that apart. Here we can see that we have documentation for the nasal, which is going to be our location. Next, we have congestion. Congestion, again, is a descriptive term, so we're going to take that for quality. It has improved with the steroids. Steroids is something that the patient is using to improve their symptoms, so this is going to be a modifying factor. And the severity now is described as mild. So that right there gives us our 4 HPI elements. And we can see for the review of systems, we have cough, hoarseness, and shortness of breath. All 3 of those are going to be systems, which are going to support our respiratory. All right, so let's fill it in. We have our location, quality, severity, as well as modifying factors. This is going to put us in an extended HPI range because we have more than 4 elements. 4 or more elements, excuse me. Review of systems. We had 1, we had respiratory. All right, so let's circle that. As far as past family, social, or medical history, we didn't have any. We know this is an established patient because it indicated the patient was established and they're there for a follow-up. So how do we determine the overall history level? Let's make sure we're reading the instructions at the bottom of our level tool. Here you can see in the lower left, it states circle the entry farthest to the right for each history area. To determine history level, draw a line down the column with the circle farthest to the left. So here, we're actually going to justify this as an expanded problem-focused history. The reason for that is even though we have, grab my little pointer here, even though this is going to be the column farthest to the left, you can see here that none is equally valid across these 2 areas as far as past family, social, and medical history are concerned. So you want to make sure that you're noting that when you're filling out your audit tool and counting up all your elements. All right, let's move on. Again, I did mention earlier, please keep track and make sure that you are keeping in line. Are you using 1995 evaluation and management guidelines, or are you using the 1997 guidelines? All right, let's take a look at that audit tool one more time. The reason you need to be cognizant of whether you're using 95 or 97 guidelines when it comes to the history, again, it's a little more pertinent in the next video when we talk about exam. But as far as history is here, again, if you're using the 97 guidelines, you can have the status of 3 or more chronic or inactive conditions in order to qualify for an extended HPI. So just something that you want to keep in mind. So let's take a look at what that would look like. So here we have an established patient coming in for a follow-up on their diabetes and their hypertension. Here we can see we have documentation of the hypertension, the diabetes, as well as osteoarthritis. So right there we have 1, 2, 3 inactive or chronic conditions. So this is going to allow us to justify an extended HPI. Review of systems is documented as general, which is our negative for fatigue, weight loss, or anorexia. General is also another term that can be used hand in hand with the constitutional review of systems. We have cardiovascular. We also have endocrine. And then we can see that we have a past medical history, or PMH, is positive for CAD, or coronary artery disease. When we add those all up, we can see that we have the HPI of 3 chronic conditions. Review of systems is at 3, and we also have the past medical history. So let's fill that in on our audit tool. Let's add all of these elements up. We have an extended HPI, our extended review of systems, past medical history, which is going to be our one area there. Follow our instructions. There we go. This is going to justify a overall history level of detailed. All right, that's all I have for you guys today when it comes to breaking down the history. Make sure that if you need additional assistance with understanding evaluation and management coding, that you are tuning in to the next video, which is breaking down the exam. Thanks, guys.